Hey everybody, this is the High Yield Emergency Medicine Shelf Examination Review tailored to the endocrine portion of the examination. So, with that being said, let's get started. Hypoglycemia symptoms can range from sweating, tremors, anxiety, nausea, dizziness, psychosis, and even as dramatic as coma. You always want to consider hypoglycemia in an unresponsive patient. Beta blockers can mask symptoms of hypoglycemia. The three main treatments for diabetes are metformin, sulfonylureas, and insulin. If the patient overdoses on sulfonylureas, glyburide, you want to expect them to become hypoglycemic. Because of the long half-life, they could get recurrent hypoglycemia. The treatment is octreotide. Metformin, on the other hand, causes lactic acidosis and hyperkalemia. Compromised renal function is the number one risk factor for someone taking metformin to develop lactic acidosis, and hold metformin 48 hours prior to IV contrast use. Hypoglycemia secondary to insulinoma and exogenous insulin use can be differentiated by the key point that endogenous or insulin made by one's own body has measurable C-peptide levels. So someone with an insulinoma will present with elevated insulin levels, but also elevated C-peptide levels. The treatment for hypoglycemia is D50 for ages greater than 8. You'll do 1 to 2 milligrams per kg. D25 if their age is 1 to 8. 2 to 4 milliliters per kg, and then D10, age less than 1, you'll do 5 milliliters per kg, and glucagon 1 milligram intramuscular or IV. And you can add on hydrocortisone for any suspected adrenal insufficiency. Octreotide, again, is used for sulfonylurea-induced hypoglycemia. And then for DKA, the pathophysiology is you want to think about the patient's body is having low insulin, so the body metabolizes triglycerides, amino acids, instead of glucose for energy. So there's gonna be an increase in the free fatty acids, and glucagon stimulates conversion of free fatty acids into ketones. So elevated levels of glucose are going to spill out into the urine, bringing with them the extra water, which precipitates dehydration and electrolyte abnormalities in these patients. Always, always, always get an EKG on DKA patients because you don't want to miss a STEMI. You need to hunt for the cause of what threw them into DKA. So think about infection, MI, trauma, noncompliance. You want to be on the lookout for all of those. And the treatment for DKA is fluids, and more fluids. Then you're going to start insulin at 0.1 units per kg per hour. You want to give potassium if the potassium is between 3.3 to 5. As insulin, remember, decreases potassium levels. And then patients respond to treatment when the gap closes. You want to get two continuous lab draws of the gap to be closed. So get the labs, and then 8 hours later, get the labs again, or whatever your hospital is suggesting you do. But you want to make sure that gap is closed not once, but 2 consecutive times. That's basically to ensure that you've completed treatment, right? And then hyperosmotic, hyperglycemic, non-ketotic state. That's just an elevated glucose level. The patient will have high serum osmolarity and lack of ketone production. So the treatment for these patients is also fluids. And then this last little bit here, I just wanted to add that alcoholic ketoacidosis is treated with dextrose, normal saline D5, normal saline, and thiamine. Thyroid releasing hormone comes from the hypothalamus, and it stimulates the anterior pituitary to release thyroid stimulating hormone, which in turn stimulates the thyroid gland to synthesize and release T3 and T4. And you want to recall that this has a negative feedback and inhibits TSH release, and T3 is the biologically active form of thyroid hormone. So when you think about hyperthyroidism, these patients are going to come in with anxiousness, tremor, insomnia, heat intolerance, weight loss, sweating, hair loss, tachycardia, palpitations, diarrhea, maybe a goiter and exophthalmos. The laboratory data are going to show hyperglycemia, hypercalcemia, elevated liver function tests, low cholesterol. You may see that they have pretibial myxedema, which is a rare manifestation of Graves' disease, and it produces a yellow, waxy skin and bilateral firm dermal nodules and plaques, which are accumulations of the mucopolysaccharides. Thyroid toxicosis of pregnancy is associated with hyperemesis gravidarum, usually resolves by 20 weeks gestation, and the presentation will be a pregnant patient in the first or second trimester. She'll have anxiety, palpitations, tachycardia. Do not think that they're having a panic attack. That's the wrong answer. If you see these symptoms in a pregnant third trimester patient, think about the pulmonary embolism as the diagnosis. Thyroid storm is a life-threatening complication of hyperthyroidism. It's a diagnosis of clinical gestalt, basically. There's no specific lab values except for low TSH, high T4. The classic presentation is central nervous system dysfunction, hyperthermia, tachycardia out of proportion to a fever. The treatment is propranolol, which blocks the peripheral thyroid hormone effects, and PTU, which blocks thyroid hormone synthesis as well as the peripheral T4 to T3 conversion. Iodine can be given 1 hour after PTU and blocks thyroid hormone release. Corticosteroids are also part of the treatment plan as well. Something else, another disorder I want you to think about is apathetic thyroid toxicosis, and that's in an elderly patient. They'll have slowed mentation with unexplained tachycardia, heart failure, and AFib are common comorbidities. It may present initially like hypothyroidism, but they just have this baseline tachycardia that's unexplained. Thyrotoxic periodic paralysis is common in Asian men. It's characterized by abrupt onset of hypokalemia and paralysis secondary to thyrotoxicosis. Switching over from the hyper states, we're going to go to hypothyroidism. And this can manifest as overtreatment of Graves' disease, dietary iodine deficiency, autoimmune destruction such as Hashimoto's, for example, and side effects of lithium and amiodarone use. The signs and symptoms are slowed mentation, altered mental status, psychosis, heart failure, bradycardia, pericardial fusion, just puffy face and extremities, which will present as myxedema. The treatment is levothyroxine. And then myxedema coma is a true medical emergency. These patients are going to have signs and symptoms of dry skin, prolonged relaxation phase of the deep tendon reflexes, non-pitting periorbital edema, and hyponatremia. The treatment is IV thyroid or T4 and hydrocortisone 100 milligrams IV. Waterhouse-Friderichsen syndrome, you'll see bilateral hemorrhagic adrenal infarcts. It's a complication of a meningococcemia. Presents with abdominal pain, vomiting, fever, hypotension. Adrenal insufficiency primarily presents as shock with hypotension refractory to resuscitation. It can have, and you can see patients will have hyperpigmentation as well. There are a couple kinds of primary adrenal insufficiency. The number one cause of primary adrenal insufficiency is autoimmune. You want to think about Addison's disease, for example. And the second cause is due to an infectious etiology. Think tuberculosis, for example. And then prolonged administration of steroids is by far the most common cause of ACTH deficiency and secondary adrenal insufficiency. Laboratory data will show hyponatremia, hyperkalemia, hypoglycemia, and the treatment is IV fluids and corticosteroids. You diagnose Cushing's syndrome with dexamethasone suppression test. SIADH is an inappropriate oversecretion of ADH, leading to overly concentrated urine, low serum osmolality, and normovolemia. Small cell lung cancer is the most common cause of SIADH. Also think of post-surgical patients as well. And then central diabetes insipidus Central diabetes insipidus is due to secretion. It's able to secrete ADH and it's able to respond to ADH administration. However, nephrogenic diabetes insipidus fails to respond to ADH administration because the kidneys are just resistant to ADH. And then pheochromocytoma, you don't want to miss this, especially if you're going to go on to be an ER physician, right? These patients will come in with palpitations, sweating, headache. Most are found incidentally on CT imaging, and the best initial screening test is a 24-hour urine for catecholamines. These need to be surgically resected. And so for the blood pressure component, they'll probably ask you this on the shelf. For pheochromocytoma, you want to first add alpha blockade, which is phenoxybenzamine, and then you want to add the beta blocker on. All right, so in terms of electrolytes, we'll just go over a couple formulas and then just talk about electrolyte abnormalities and balances and then talk about sodium, and then we'll be done for this video. So the anion gap is sodium minus chloride plus bicarb. Decreased anion gap, you want to think of things like hypoalbuminemia, multiple myeloma, hypercalcemia, hypermagnesemia, and lithium toxicity. Increased anion gap, you want to think about mud piles. That's that mnemonic, recall. Metabolic acidosis and hypokalemia, think about a diarrhea. Metabolic acidosis and hyperkalemia, think about renal failure. Metabolic alkalosis and hypokalemia, think about vomiting. And then the serum osmolarity is 2 times the sodium plus glucose over 18 plus BUN divided by 2.8. This tells you if something else is present in the serum. So, for example, osmolar gaps greater than 10, look for things that are not normally in the plasma or in the blood that are contributing to this elevation or this gap. So these would be things like ethanol, ethylene glycol, isopropanol, methylene glycol, mannitol. Rhabdo is the most sensitive test for diagnosing rhabdo is the CPK, which will be 5 times the upper limit. You'll see the presence of myoglobinuria, hyperkalemia, and hyperphosphatemia, in addition to hyperuricemia. Rhabdo patients are at high risk of kidney failure, so the treatment is IV fluids. Hypermagnesemia will present with hyporeflexia, respiratory depression, and heart block. The treatment is IV calcium and dialysis. Think about a pregnant patient getting magnesium, right? And you're constantly checking those reflexes. So diminished reflexes is actually the earliest sign of elevated mag levels. And then hypomagnesemia is just really straightforward. You just give them IV magnesium. Stones, bones, groans, psychiatric overtones are the symptoms of hypercalcemia, primarily caused by hyperparathyroidism. The EKG will show shortened QT. The treatment is IV fluids and calcitonin. Hypocalcemia is caused by hypoparathyroidism. Think like the post-surgical removal, right? Renal failure, vitamin D deficiency, pancreatitis. The EKG will have prolongation of the QT. Always correct the calcium with the calcium albumin correction formula, which is listed here for you to see, and you want to treat it with calcium gluconate and magnesium. Hypokalemia, you'll see patients come in with muscle weakness, cramps. The EKG will have a U wave, and the treatment is replete potassium, check magnesium levels simultaneously. Hyperkalemia is most often caused by lab error, so you just want to repeat the lab draw. EKG will show peak T waves, increased PR interval, flattened P waves, prolonged QRS, and the treatment is calcium gluconate to stabilize cardiac membrane. Then you want to start adding in things like insulin, D50, beta agonist, Kxalate, Localma. And lastly, this is hypernatremia from the perspective of the ER shelf exam. So symptoms of hyponatremia kick in around 120, so the patient will be confused, anorexic, lethargic, have nausea, vomiting. There are 3 categories of hyponatremia: hypovolemic or low volume hyponatremia. The patient's just dehydrated, so give them fluids, really straightforward. Hypervolemic hyponatremia, there's a decrease in the free water excretion, so you treat with IV fluids and loop diuretics. Euvolemic hyponatremia, treatment is mostly fluid restriction, give or take adding on loop diuretics. This is like due to SIADH or psychogenic polydipsia. Slowly correct the hyponatremia, 1 milliequivalent, 2 milliequivalents per hour in acute cases. Just to be clear though, up to date, actually, in other like very verified sources, recommend a more conservative correction goal of 4 to 6 milliequivalents per day to avoid something called central pontine myelinosis, which is the irreversible neurological disorder from overly rapid correction of severe hyponatremia. And then hypernatremia usually results in patients with elevated serum osmoles who cannot sense their thirst response. So this is like elderly, altered patients or infants. If they're able, you want to replete with oral fluids. The max rate of correction is 12 milliequivalents per day in these patients. And that's it. If you have any questions, leave them in the comments below. And thank you all so much for your time.